Hi everyone, this is FMGE-PYQ session for obstetrics and gynecology. Exam is just few days after, so we will quickly see all the previous year questions and the related topics for FMG exam. This is going to be a very short discussion. Let's just quickly get to it. Yes. So first, we will discuss the normal pregnancy and antenatal care. Let's start with the question. On the right side corner, you will see the year in which question has been asked. On the right upper corner, you will see that. Now, what is the best ultrasound parameter for assessment of gestational age? Remember, for assessing gestational age, the best parameter is always crown droplet. CRL is the best parameter. Now, if the question specifically mentioned the best parameter in second trimester, CRL is not used in second trimester. The duration up till which CRL is used is from 11 to 14 weeks. Only till this duration, the CRL is used as the best parameter. Beyond that, in second trimester, the best parameter is BPD. So BPD is the best parameter in second trimester. Overall, the best parameter is crown rump length. Ideal number of antenatal visits asked in FMG 2024. So according to WHO, they want at least 8 visits should be there. So ideal means minimum visits. So minimum visits are 8 according to WHO. But according to Indian guidelines, if question is asked according to NRHM, the minimum visits is 4. Since in India, 8 visits is too much for a woman, 4 is the ideal minimum visits. Earliest sign of pregnancy on ultrasound. So what is the first sign that you see when you see ultrasound of a baby? First, you see baby's home, which is the GSAC. GSAC is the earliest sign that is seen at around 4.5 to 5 weeks of gestation. Now remember, when you see on an ultrasound picture, just seeing a GSAC doesn't confirm it is intrauterine. Doesn't confirm it is not ectopic. Why? Because it can be a pseudo GSAC. Pseudo GSAC is seen in ectopic. So the earliest sign for intrauterine pregnancy, the earliest sign that confirm intrauterine pregnancy, yolk sac. Earliest sign that confirm the live pregnancy. If the yolk sac is seen, it means your pregnancy is in the uterus. That doesn't confirm it is live. The first sign of live pregnancy is fetal cardiomyopathy. Right? So remember these, the earliest intrauterine and the earliest sign for live growth, for a live pregnancy. 22 weeks ultrasound shows marginal placenta failure. When should the follow-up of ultrasound should be done? So when the placenta in the early weeks is shown to be marginal, means reaching the lower uterine segment. There is something called as placental migration that happens. And on repeat ultrasound, that placenta migrates up. So the findings of placenta previa are always reconfirmed. When? At 32 weeks. So whenever you see placenta previa at 20 weeks, you always reconfirm at 32 weeks. And after that, you again reconfirm at 36 weeks to decide the mode of doing. Remember few things about placenta previa. Placenta previa, nowadays, there are only two types, that is low-lying and placenta previa. Only these two distinctions are there. The mode of delivery for all categories of placenta previa now is cesarean section. The cesarean section done at 37 weeks is the mode of delivery for all placenta. Whereas if you talk about abruption, please remember abruption, it is detachment of a normally situated placenta. In abruption, patient is at high risk of DIC. So in case the fetus and mother are stable, they are stable, the treatment for abruption is normal vaginal. We don't do cesarean unless there is FHR deterioration, unless the maternal vitals are disturbed. Unless these two factors are problematic, that fetal heart is going wrong or maternal vitals are going wrong, unless these two are there, for abruption, we go for vaginal delivery. For placenta previa, we go for cesarean section. Okay? We'll keep seeing little extra points in each question that we can see. Folic acid therapeutic. Therapeutic dose is given in those who are at high risk of neural tube defect. So the normal dosage of folic acid is 0.4 milligram. But the therapeutic dose is 10 times, which is the 4 milligram. That is the therapeutic dose, right? 4 milligram is the therapeutic dose. Now, question. In Indian scenarios, in Indian iron folic acid tablets, the dosage of folic acid that is used in the tablets is 5 milligram. Okay, so the static dosage of folic acid that we use in our, we generally get tablet of 5 milligram. That is more easily available. But remember, therapeutic dose is 10 times of the normal dose. So preventing neural tube defect, the dose is 0.4 mg or the 400 mcg. And therapeutic dose is 10 times higher, which is 4 mg. Therapeutic dose is given in people who have high risk of neural tube defect, like previous baby with neural tube defect. The patient is obese. The patient has malabsorption. Patient has family history of neural tube defect. Patient is on anti-seizure medications. These are the indications of high risk of neural tube defect. Who use therapeutic folic acid? And it has to be started 3 months prior. It has to be started 3 months prior conception. Which vaccine can harm if it is given during the pregnancy? Which vaccine can harm? Remember, live vaccines are not given in pregnancy. Live vaccines like MMR is not given in pregnancy. Okay? Then varicella, it is a live vaccine not given in pregnancy. One vaccine, it is not live, but we don't have enough researches, not given in pregnancy. So varicella is a live vaccine. Influenza, yes. Influenza has two varieties. One is live, nasal vaccine, not given. But the killed influenza vaccine, which is injectable, that is given. Babies is not a live vaccine. It can be very well given. Yellow fever. It is the only live vaccine allowed in pregnancy. So remember this, only live vaccine allowed in pregnancy is yellow fever vaccine. Okay, next question. Antigen dose given to Rh negative mother after chorionic sampling. So now, according to the recent guidelines, whenever you give anti-D at less than 20 weeks, the dose is 150 mcg. And when you give it after 20 weeks, the dose is 300 mcg. Okay, so dose for chorionic villus sampling. Do we know chorionic villus sampling is done at what gestation? Yes, it is done at 14 weeks of gestation and the dosage is 150 mcg. So any sensitizing event at less than 20 weeks, like bleeding, placenta previa, chorionic villus sampling, anything happens, threatened abortion, you give anti-D. For all kind of abortions, medical, surgical abortion, we give anti-D. After 20 weeks sensitizing event, we give anti-D 300 mcg. Okay, again, anti-D given at 28 weeks for prevention of immunite isoimmunization. We give anti-D at 28 weeks to everyone. The dose is again 300 mcg. Okay. Then next question. What is the dose given after delivery? Once a patient delivers, do we give anti-D after delivery? Yes. If the baby is Rh positive and there are no antibodies still, it means DCT negative. No antibodies Rh positive. We will give mother anti-D again and the dosage is 300 mcg. Glucose dose for GTN screening in pregnancy. Again, what is the glucose dose? We know the answer. Few things. When is the screening done? The screening is done twice. At first visit and at 28 weeks again. Right? This is the routine antenatal diabetes screening in our country. What do we use? We use 75 gram OGTP according to the DIPSI criteria. Next question. According to DIPSI, does the patient need to be fasting? No. We don't need fasting blood sugar in the DIPSI. What is the value that will indicate impaired glucose or GDM? More than 140 will indicate gestational diabetes mellitus. Remember, GDM never have very high sugar. So very high sugar, which is more than 200, is not GDM. It is overt diabetes. So whenever sugars are very high, like this, sorry, 126, It is always overt diabetes. Home-based pregnancy test. The kit that you use, what does it detect? It detects beta HCG. It detects beta HCG. The kit detects beta HCG for confirming the pregnancy. Important, when does beta HCG start appearing in the urine? When it becomes detectable? It becomes detectable 14 days after fertilization. So 14 days after fertilization, you can detect your urine pregnancy test. Or in other words, you can say UPT can become positive 2 days before missed period. 2 days before missed period, the beta HCG start getting detected in the urine. Right? A pregnant woman faint while lying down. This question has been asked 100 times. All of us know when she faints while lying down. Why? Because it is compression of the IVC, called as supine hypotension syndrome due to compression on IVC. All of you know that. Which is an abnormal heart sound during the normal pregnancy. Some heart sounds are normal. What are the normal heart sounds? The first heart sound becomes loud. The S1 becomes loud and it is split. It's loud and splitting of S1. This is first thing. Second thing, that you start listening because the blood is being ejected out loudly, it is being ejected out forcefully. You start hearing an ejection systolic murmur. An ejection systolic murmur start appearing. The next thing that appears, you start hearing a ventricular gallop. Ventricular gallop means when the ventricle open for filling the blood, it is the gallop sound, which is S3. All this is normal. What is not normal? Diastolic murmur. Diastolic murmur is not normal. And what else is not normal? S4. That is not normal. Okay. Next, maternal medicine. Antihypertensive contraindicated in pregnancy. The antihypertensive that we can't get is the ACE inhibitors. ACE inhibitors, AT antagonist, then sodium nitroprusside. Sodium nitroprusside is the last choice in case of emergencies, as such they are avoided in pregnancy. Similarly, diuretics, avoided in pregnancy. Completely contraindicated, ACE inhibitors, AT antagonist. What you can give is nifedipine, labetalol, methylone. They are very safe. Labetalol is alpha and beta blocker. It is both alpha and beta blocker. Being beta blocker, you can't use it in asthma. Okay. Calcium channel blocker. Which is calcium channel blocker? Nifedipine is calcium channel blocker. Pregnant women with asthma presents with severe hypertension. What will be your drug of choice? Can you give labetalol in asthma? No. ACE inhibitor contraindicated in pregnancy. Oral labetalol? No. I can give nifedipine. If methyl dopa would have been there, I can give methyl dopa also. Treatment of Plasmodium vivax malaria in pregnancy. So Plasmodium vivax treatment is chloroquine. Chloroquine is the treatment for vivax plasmodium. So little bit discussion here also. No, no space. So for vivax malaria, these are chloroquine sensitive. Treatment of choice is chloroquine in any trimester. In all the trimester, chloroquine can be. If patient is chloroquine resistant, then you give quinine. Now, something that has changed recently by WHO, the treatment for falciparum malaria. Treatment for falciparum malaria. Remember, it has been changed. Irrespective of gestation, the treatment for falciparum malaria is artemether and lumefantrine. Initially, it was said that artemether and lumefantrine cannot be used in first trimester, and we used to use quinine. But now, in 2026, changed. P. falciparum, the treatment is artemether lumefantrine in first, second, and third trimester. Treatment for severe malaria, this also you remember, treatment for severe malaria is IV artesunate. So these are the beautiful drugs. IV artesunate for treatment of severe malaria. What's in pregnancy? What is the treatment of choice? So remember, for what's the treatment of choice in pregnancy is gravity. Warts can be treated by various chemicals. Chemicals like trichloroacetic acid, imiquimod, then cinecachicins, podophyllones. Now remember, in any sensitive area like urethra, cervix, inside vagina, in any sensitive area and in pregnancy, these cannot be used. So imiquimod, cinecachicins and podophyllones cannot be used in pregnancy and what's in a very sensitive area. Trichloroacetic acid can be used in pregnancy, but they have should not be preferred. It can be used, but it should not be preferred. The best in pregnancy is cryotherapy, right? So if why I'm telling you this, if these four options come in pregnancy, what to be used? Then you will mark TC, trichloroacetic acid. Okay? Now, some questions on labor and delivery. Post-term pregnancy. See, remember these definitions. Less than 37 weeks is preterm. 37 weeks to 41 weeks is term. 41 weeks से लेके 42 weeks is late term. And beyond 42 weeks is post term. Why this distinction? When the pregnancy crosses 42 weeks, that is the time when placenta actually starts aging. Now the baby is actually at risk beyond 42 weeks. The lichens start reducing, placenta starts aging. Now this is a high risk time beyond which the baby should get delivered. So that is why they say 42 weeks is now an aging placenta, post term. 41 to 42 weeks they have labeled as late term. It means in this period, try to deliver the baby. Try to deliver the baby in late term and not let it go beyond post term. So post term means an aging baby, an aging placenta beyond 42 weeks. Okay? Post dated, you have given an expected date of delivery, right? Beyond that. So post dated as such no clinical significance, but post dated is beyond your date, beyond your EDD, 40 weeks. Okay. Correct order of Loki after delivery. The correct is first it is rubra. It is red containing red blood cells for 1 to 4 days. Serosa for 4 to 10 days. It is whitish, pinkish. Alba is creamy white from 10 to beyond till 6 weeks. So till 6 weeks, lochia is excreted for 1 to 1.5 months and sequences rubra, serosa and alba. Rate of cervical dilation in active phase of labor is, so it is rate of cervical dilation is different in primary and multi. In primary, the rate of cervical dilation is 1.2 centimeter per hour, and in multi, the rate of dilation is 1.5 centimeter. This number you have to remember. Questions previously have been asked on this number. Now here, this exact figure is not given. So what will you mark? That comes something around it, 1 centimeter. It looks more accurate because according to the partogram, now this is a theoretical definition. When you plot on a partogram, the rate should be 1 centimeter per hour. Partogram is specifically made for 1 centimeter per hour. So for partogram, normal is 1 centimeter per hour. But if you ask theoretically, this is normal. Just after delivery, the uterus is at level of. So immediately after delivery, uterus is 1 kg and it comes at lie at the umbilicus, at the upper body of umbilicus. Okay? So just after delivery, it is at umbilicus. It stays there for 24 hours and then the involution starts at rate of 1 finger breadth per day. You can say 1.25 centimeter per day. So 1 finger breadth, 1 finger breadth per day after 24 hours. So once the baby delivers for whole day 1, it is on uterus. On day 2, it goes 1 finger below. On day 3, it goes 2 finger below. On day 4, it goes 3 finger below. Right? And it does the same till at 2 weeks. It is completely intrapelvic after 2 weeks. and it goes to its normal size. At what time it goes to its normal size? Not 6 weeks, 4 weeks. At 4 weeks, uterus goes to its normal size. ठीक है, 2 weeks में इंट्रा पहले, 4 weeks में it is normal size. Lactation sequence. What is the sequence of lactation? See, before the lactation process starts, the breast has to prepare. And that process starts in pregnancy. Breast starts getting prepared. That is mammogenesis. So mammogenesis, there it is. No, it's not. This sequence is not. Mammogenesis, when the breast starting preparing. Then once the breasts are prepared, lactogenesis starts. Due to the hormone prolactin, lactogenesis, yani ki milk synthesis starts. Once the baby is delivered, milk ejection starts. By hearing the voice of the baby, touching the baby, milk ejection start galactokinesis because of oxytocin. And maintenance of this ejection and maintenance of this process is galactopoiesis. Galactopoiesis is maintaining lactation due to prolactin. Okay? Aim of Ridgen maneuver. What is Ridgen maneuver? Result in Ridgen maneuver, when you are trying to deliver the baby, the mother is fatigued, can't push, and you are trying to pull out the baby. One hand is below the baby chin, with the another hand you are holding the occiput, trying to pull the baby out. The main aim of Ridgen maneuver is to prevent the perineal. To prevent perineal trauma, you use Ridgen maneuver. What else you use? Hands-on technique. In hands-on technique, what do you try to do in hands-on technique? You try to maintain the flexion. You try to maintain the fetal head flexion by hands-on technique and protect the perineum and deliver it. Where is vacuum cup when it is applied on fetal head? Vacuum cup has to be on something called as flexion point. It has to be on the flexion point. Where is flexion point on the fetal head? The flexion point is, if this is your posterior fontanelle, this is your anterior fontanelle. The flexion point is 3 centimeter in front of the posterior fontanelle. Here. It is 3 centimeter in front of posterior fontanelle. So vacuum has to be placed so that the center of the vacuum is on the flexion point. So when the center is on the flexion point, the rim of the vacuum is on the posterior fontanelle. So how I can describe? The center of vacuum is 3 centimeter in front, or the rim of the vacuum is on the posterior fontanelle. One more way of saying, the center is 6 centimeter behind. That is the another way. The center of flexion point is 6 centimeter behind the anterior fontanelle. So either 6 centimeter behind or 3 centimeter in front. This is the flexion point. And when it is kept on flexion point, the rim of the vacuum is on posterior fontanelle. Okay. Oxytocin is contraindicated. As such, oxytocin is a very safe drug, but it is contraindicated when you do not want to have normal delivery. The aim of oxytocin is one, preventing PPH, but in labor, when you augment delivery. So in abnormal line, you will not use oxytocin. You don't want to augment delivery. Can you use oxytocin in heart disease? Yes. Once you are giving oxytocin infusion, it should be in a controlled manner. But yes, iron oxytocin can be very well given in a heart disease patient after delivery. A partogram showed no progress in 4 hours. Contractions are moderate 3 by 2. Are they good? No. Good contractions are 4 to 5 in 10 minutes. So it's not a good contraction. Since 4 hours, nothing is happening. You have to intervene. How? You want to augment the contraction. How will you augment? 2 ways. Either ARM or oxytocin. Which is better? ARM, artificial membrane rupture, is done only when the cervix is dilated, only when your Bishop score is good. When it is not mentioned, oxytocin is better. Oxytocin augmentation, and when the cervix is open, then you do ARM. You will not do cesarean. There is nothing to show cesarean. First, you try to intervene. There is no sign of instrumental delivery. Instrumental delivery is done when it is fully dilated. Identify the first. Small forceps means I need less force. When it is long forceps, I need more force. And there is no extra curve, normal pelvic and kyphic curve. This is outlet force. Keel and forceps, remember keel and forceps has a different lock. It doesn't have this English lock. It has a sliding lock. And the one differentiating feature of the keel and forceps is when the forceps is locked, normally, when all the forceps are locked, the handle oppose each other and the shanks are far apart. In keel ants, it is opposite. In keel ants, once you lock it, the shanks are opposing each other and the handles are far apart. This is how a keel ants forceps. The shanks oppose and handles are apart. Okay? This is how outlet. And outlet and mid cavity forceps, what is the difference? The size. Mid cavity means you need more force. It is longer. Outlet is smaller. Why not the DAS forceps is answered? DAS is a type of outlet force. Okay, so it is an outlet force overall. Primary gravidae at 5 centimeter 1 km. After 3 hours, only 1 centimeter dilation. We saw in last question, dilation should be 1 centimeter per hour. It is slow? Yes. What will you do? Will you do cesarean? No. Unless the fetal heart deteriorate, do not write down cesarean on the first book. The first answer is always intervene, always augment. What will you do? You will intervene. Will you induce labor with oxytocin? Induce labor matlab start the labor. A patient hypertensive, you induce labor. You start the labor. She is in labor. You are augmenting. She is slow. So when you try to make the labor process fast, it is augmentation. When you are trying to start the labor, it is induction. So you will need an intervention. Intervention is needed, also called as augmentation, not induction. Okay? Next, malpresentations and operative delays. Presenting diameter in face presentation. Face presentation. Now this is face. What will be the diameter? Submento, this pragmatic. Submento-pragmatic is the presenting diameter. Now let's quickly revise the diameter. In fully flexed head, suboccipito-pragmatic. Suboccipito-pragmatic, this 9.5 in fully flexed. Slightly extended, occipito-frontal. In brow presentation, when this is the presenting area, mento-vertical. Mento-vertical. 9 point, it is 14 centimeters. Okay? Identify the type of pelvis. What is this pelvis? Does it look something like gynecoid or the transverse diameter is more? And it is more flat. Compare it with the gynecoid pelvis. Gynecoid pelvis is round. The inlet is round. It is not like this transversely over. So this is platyploid pelvis. Gynecoid, see here. Gynecoid is inlet is rounded. And it has those marks. It's not flat. Whereas platyploid, can you see flatness here? And it is transversely over. Transverse. Anthropoid is AP. Anteroposterior. Android, heart shape. Anteriorly angulate. Okay, like in these images. First maneuver for shoulder distension. When the shoulders are stuck, head has come out, shoulders are not come out. What will be your next maneuver? Remember helper, you ask for help, you give episiotomy, then you first start with external maneuvers. Always, first externally manipulate, then you insert hand internal. So first thing is always suprapubic pressure and maneuvers. They are done together. Suprapubic and maneuvers. So this is first. Once it is not successful, then you go to the internal maneuvers, which is the Rubin's-Cox method, which is the delivering the posterior shoulder. Right? Now, in this question, Mac Roberts and suprapubic both are given. As such, both are done together. But in case the question comes with both these options, Mac Roberts is chosen first. All the books always mention Mac Roberts first and then suprapubic. They mention Mac Roberts and suprapubic. So suprapubic se pehle Mac Roberts is mentioned. Hence, it is decided that when both the options are there, you will choose Mac Roberts. This is Rubin's one maneuver. Rubin's two is rotation of the rotational maneuver, where you rotate the baby to bring the posterior shoulder anteriorly. That is Rubin's two. After Mac Roberts failed in shoulder dystocia, next step, suprapubic. Easy. If suprapubic fails, then you go inside and try to bring the posterior shoulder out. It is not given an option. Go inside and do the rotational maneuver, which is first Woods, second Rubin's two. So if suprapubic fails, next is this one. That also fails, Gaskin. This also fails, last Zavanek, Cesarean. What is shoulder dystocia? Head come out, but shoulder doesn't follow even after 1 minute. That is shoulder dystocia. Once the shoulder dystocia has been diagnosed, the delivery should take place within 4 minutes. Delivery should take place within 4 minutes, otherwise baby will have headaches. Fracturing clavicle to facilitate baby. Why do you fracture clavicle? Something related to this. Why will you fracture clavicle? If I want to reduce this diameter, it means shoulder dystocia. What do we call it? Pleodotomy. And pleodotomy is done in shoulder dystocia. Symphysiotomy means you make a cut in the symphysis bone and separate that. That was very in old times done in shoulder dystocia. You open up the pelvis so that baby can deliver. Now it is not done anymore. Which is not a contraindication for vaginal delivery after cesarean. So VBAC, vaginal birth after cesarean, not a contraindication. It means I can do a VBAC. In previous classical cesarean, can I do a VBAC? No. I don't know the scar. Can I do cesarean? Previous to LSCS, can I do the vaginal delivery? No. Previous macrosomia. If there was previous macrosomia, cesarean was done. Can I not try vaginal delivery now? Of course I can. So VBAC is contraindicated when there is a history of classical cesarean. When there is a previous J-shaped incision. Okay? When it is a breech baby. When previous two LSCS are there. In these indications, vaginal birth is not tried in cesarean. A multigravida with previous C-section. Again, best candidate for vaginal birth. What is the best candidate for you? So last year they asked 2023 which cannot undergo VBAC. Now they ask which can undergo VBAC. Previous transverse scar. So previous was a transverse LSCS scar. Something like that. Yes, I can try, definitely. I should know the segment, but yes. Breech me, can I try vaginal delivery? Previous cesarean, now breech. Can I try? No. Previous classical cesarean, no. Transverse line. The baby is transverse line. Can I deliver that baby vaginally? No. Previous transverse scar. Yes, that's a normal scar. Previous vertical scar? No, vertical scar means classical. Classical scar is vertical. Prerequisite for vaginal breech delivery at 40 weeks. Again on question on VBAC. Prerequisite for vaginal breech at 40 weeks in active labor. Achha, now not on VBAC, it is a vaginal breech. Now you are trying to deliver a breech baby vaginal. What all should be in place? What all you should have to check? In that place, emergency LSCS facility should be available. Yes. Experienced midwife only? No. You need experienced anesthetist and pediatrician also. No specific prerequisite if fetal weight is less than 3.5. Absolutely no. If the fetal weight is normal, there are many prerequisites. Prerequisite means you have to take care of these things. Then only a breech baby can be delivered vaginally. Like Baby should not be too small. Baby should not be too heavy. Then it should not be an extended neck. Extended neck like this, stargazing sign. Not allowed for delivery. Footling bridge, beach. Not allowed. Spacious pelvis should be there. So these are also the prerequisites. There should be LACS facility, there should be a pediatrician, there should be a trained person there. Okay? If division in a zygote occurs between 9 to 12 days, the outcome is, so always remember you have to divide your twins into 1 to 3 days, 4 to 8 days, 9 to 12 days. 1 to 3 days. I have given that in my various lectures also, how to remember that. See, twins are like friends. The longer they stay together, difficult it is to separate. If you separate them early, they will get separated. If you separate them late, very difficult. So if separation happens early, you can separate them diagnostic diagonally. Different rooms, different house, no problem. If separation happens at 4 to 8 days, they have become friends. So they agree to stay in different rooms, but they want same house. Monochorionic diagram. In same house, two different rooms. This was different house and different rooms. For 9 to 12 days, they have become more good friends. They will say, we will stay in the same house and in the same room. Monoerotic, monopoly. Beyond 12 days, now they are stick with each other. Siamese twins, conjoined twins. So here answer is monochorionic monopoly. Okay. APH. Identify the type of placenta previa. Can you see here? Partial placenta previa, marginal. It is, you can say marginal. No. Yes, sorry. Partial is the one reaching the os. It's an older classification. Can you see it is reaching the os? It is partial. Marginal is the one that is reaching only till lower uterine segment. Okay, marginal is in lower uterine segment, not up till os. This one is up till os. Complete is completely covering the os. Placenta seems adhered to uterus, perforated and entered the bladder. It is percreta. Accreta is adhered, tightly adhered. Increta reaches the myometrium and percreta goes beyond. Which layer is missing in these? Metabush layer. It is missing, we call it placenta accreta syndrome, PAS. Always delivered by cesarean, always. 28-week pregnancy with sudden severe pain, tender from uterus and bleeding. Whenever it is pain with bleeding, it is abduction. It is pain, less bleeding, it is bleeding. A woman at 17 weeks, BP 140/80. Okay, systolic is high. No proteinuria. What is it? Anything less than 20 weeks in hypertension is chronic hypertension. If this patient with no proteinuria would have been beyond 20 weeks, beyond 20 weeks may high BP, but no proteinuria, gestation. Beyond 20 weeks, high BP, proteinuria present, great. Okay. Anything can be high, either systolic or diastolic. Both should be high. No. Any one is high, stop. Any one is even high, then that means it is hypertension. A woman at 34 weeks of gestation, BP is this much. What is next? 34 weeks, BP is high. What do I want to do? Whether she is preeclampsia or gestational hypertension. Preeclampsia is a severe condition. Gestational hypertension is not. Preeclampsia is multi-organ. I will do all the tests, but the very important test to differentiate is urine flow. Urine dipstick more than equal to +1, or in 24 hours 300 milligram, or urine protein creatinine ratio 30 milligram per millimole. All that indicates significant protein. It indicates preeclampsia. Fetal monitoring. Variable deceleration on CTG indicate what is variable. It has no relation to contraction. So remember, when the deceleration is directly corresponding to the acceleration, it is early deceleration. Early deceleration is due to head compression. When the contractions are coming, and decelerations are happening little later, like this, little later, late deceleration due to placental dysfunction. When the deceleration has no relation to contraction, variable deceleration caused by cord compression. So cord compression causes variable deceleration. You can remember by wheel chop. Variable, so wheel chop, wheel chop. Variable deceleration, cord compression. Early deceleration, head compression. Acceleration are okay. Late deceleration due to placental dysfunction. Right? Fetal anemia is best monitored by. Now, if the baby is anemic, like in RH incompatibility, how will you know? You can't do hemoglobin for the baby, right? So when anybody becomes anemic, the blood supply to brain increase so that blood can get enough oxygen. It is the most vital organ. To provide good oxygen to brain, blood flow increase. So the peak systolic velocity increase of brain, middle cerebral artery, PS. So to know anemia, we do middle cerebral artery peak systolic velocity. If it is high, more than 1.5 moles of million, it is anemia. Used in RH incompatibility, especially use it in RH incompatibility. We also use it in fetal compromise and IUG. Okay. A patient is having profuse bleeding during cesarean, oxytocin has been given. What will you do next? Always step by step. Oxytocin has been given. Still no bleeding is not stopped. Then balloon tempo. If balloon tempo are not given an option, devascularization. Next step. No, sorry, before devascularization, delimation. Next step, devascularization. Still no answer to study. Okay. A patient has been in prolonged labor. A tight ring is observed at upper and lower uterus. Prolonged labor, a tight ring. Can it be physiological? A ring that is visible per abdominal, and it is happening in prolonged labor, and it keeps on ascending. It is happening because the upper part is getting shorter and lower part is getting dilated. It is obstructed. And with the time, this ring moves up. That is Bandel's. What do you do in Bandel's ring? You stop augmentation, you stop oxytocin, hydrate the patient, take her for cesarean. Otherwise, uterus will rupture. Patient with uterine inversion. Uterus has inverted. Uterus is inside out. What is the first step? Help, always. Will you remove the placenta? No, the placenta is never removed. If you will remove placenta, it will become more worse. The next step is stop oxytocin. Immediately stop oxytocin, not start, stop it. Once you stop it, now push it in. Deposit the uterus with the placenta attached. Where? Will you take her to OT? Patient will expire in that time. You don't have that push in the labor. Then and there, with placenta attached, push it in. You shift her to OT only when you are not able to deposit in labor. When you are not able to deposit in labor, then you shift her to OT. Cesarean and postpartum. A primary gravida delivers a male child without complications. How many hours should she please feeding start? We all know. Immediately. Or you can say if it is cesarean, within 1 hour. Okay. Absolute contraindication for breastfeeding. As such, very few in contraindications. HIV, hepatitis B, HCV, everywhere you have to feed the baby. Breastfeeding is contraindicated in very few conditions, like galactosemia. Baby can't tolerate galactose. Then, what else? Active tuberculosis. Patient has active tuberculosis. Then, what else? The patient has varicella with the lesion on nipple. Lesion of varicella chickenpox is on the nipple. Then, you will again not. Okay, these are the only very few patient on anti-cancer drugs. Very few contraindications. Patient on taking some recreational drugs. Patient taking cocaine. All these are contraindications. In all other infections, patient should breastfeed their baby. There is no problem. Exclusive breastfeeding is for 6 months. Okay? After that, you will give the add-on feed plus breastfeed till 2 weeks. So after that, you will give add-on plus it is advisable by government that you should breastfeed for at least 2 weeks. Not compulsory, but yes, advisable. On 7th day of cesarean, patient has continuous dribbling of urine. Continuous urine dribbling. What should have happened? Something might have happened in cesarean that is dribbling. What would have happened? Injury. Some fistula has come. Vasaico. How will you know? There are various types of fistula. If it is continuous dribbling and patient is not passing urine and continuous dribbling, it means bladder is constantly getting empty. Vesicovaginal fistula. If the dribbling is happening only while she is passing urine, only when she is passing urine, then the dribbling through vagina happens. Ureterovaginal fistula. She is passing urine through urethra, then only dribbling. Then continuous dribbling, but she is passing urine also. It means her bladder is getting filled. Bladder is not getting empty. Bladder is getting filled. Continuous dribbling is coming from somewhere else. Ureterovaginal. One ureter is dribbling the urine, one ureter is filling the bladder. She is passing urine also, she is constantly dribbling also. Ureterovaginal. In the vesicovaginal, she doesn't pass any urine because bladder is never full. Obstetric audit. See, any hospital has audit. The purpose of audit is you want to improvise the conditions. You want to improvise the hospital conditions and everything. So audit purpose is when some behavior change can reduce that risk. Okay, when something has happened due to not exactly doctors, but due to somebody's inefficiency, due to hospital staff's inefficiency, if something happens, you do an audit so that it doesn't happen again. Like fetal death, injury to fetal health. Not preterm labor. Preterm labor doesn't happen because of a staff. It happens because of genetics, because of various conditions. So preterm birth, there is no audit. Audit is always done when you see that some iatrogenic thing was in. It could have been prevented. Postpartum hormone dispensable for milk ejection. We have seen that milk ejection. Okay. MTP for contraceptive failure can be done up till with gestation. Remember, FTP there are 3 gestations. Up till 20 weeks, everyone is allowed, even the MTP failure. But from 20 to 24 weeks, MTP failures are not allowed. If you have become pregnant with MTP failure, you should have come earlier. 20 to 24 weeks, only when there is a fetal risk, there is maternal risk, rape or incest is there. Beyond 24 weeks, only because of fetal risk, significant fetal problem, then. So MTP for contraceptive failure, 20 weeks. Married lady with failed contraception at 26 weeks, request termination. Can you terminate? No. Continue pregnancy if no fetal. If no anomaly, continue. Will you take medical board? No, you will not even go to medical board. For this indication, nobody goes for medical board. Medical board permission is needed only when there is a fetal anomaly and a termination is needed beyond 24 days. Okay. Here you need permission of 1 RMP. Here you need permission of 2 RMPs. A mentally challenged girl is pregnant for termination whose consent is. See, beyond 18 years, if she is mentally stable, only women consent is. Husband consent is not. If she is mentally stable, if she is less than 18 or mentally not stable, you need consent of a legal guardian. Not partner, not doctor, not parents, legal guardian. Property 380A has a lifespan of how much lifespan? 10 years. Okay? Property 375, 5 years. Marina, 5 years. Postpartum property inserted many times. So you can insert it immediately after delivery and up till 2 more days, up till 48 hours. If patient refuses, then it has to be delayed till 6 weeks. Okay? Similarly, postpartum ligation. Postpartum ligation can be done within 7 days. It can be done within 7 days. Following vasectomy, a man is advised to use contraception. Why? If you have cut the vas deferens, there are sperm still there in the whole internal genitalia. There is a whole lot of sperm present, which will need 3 months. It needs 3 months to wash out all the sperms. So after 3 months, semen analysis done, which shows azoospermia, then only we declare him as a infertile person. Remember, vasectomy doesn't make you infertile immediately. Pubectomy makes a woman infertile immediately. MEC category 1 for cirrhosis, no restriction. Diabetes, hypertension, hyperlipidemia. Diabetes may uncontrolled diabetes category 3, controlled diabetes category 2, hypertension 2, lipidemia no. HIV. This is something you don't have, please don't memorize MEC categories. Medical eligibility. You can't memorize. Just think. It is hormonal pill. Can you give it to a diabetic, hypertensive, breast cancer, stroke patient? No. Can I give it to HIV patient? Of course. Okay, whatever increase the risk of stroke, I can't give hormonal pills. What I can give IUCP. I can give progesterone pills in them. Contraindication to subcutaneous implant is progesterone. I can give it in hypertension, diabetes, in PID also I can give it. Undiagnosed genital bleeding. Until I diagnose the reason for genital bleeding, it might be a cancer, I can't give it. So in undiagnosed genital bleeding, hormones cannot be. Another contraindication for progesterone. Progesterone as such is very safe. But one place where you cannot give any form of progesterone is breast cancer. You cannot give any form of progesterone. Unprotected intercourse 5 days of best. Yani you need an emergency contraceptive. Emergency contraceptives are 3 types. Levonorgestrel pill. How much is the dose? 1.5 milligram within 70 days. Next is ulipristal 30 milligram within 5 days. But the best is copper. Copper T is the best emergency contraceptive given within 5 days. OCPs do not protect against which cancer? Remember CEO? OCPs protect against endometrial cancer, ovarian cancer, and colon cancer, not against cervical cancer. PCOS. A woman with hirsutism shows very easy string of pearl appearance. String of pearls, PCOS. A girl with irregular, so string of pearls is ultrasound criteria. Theoretically, you can say more than 10 cysts, less than 10 mm in size, ovarian volume more than 10 cysts. It is rule of 10. More than 10 follicles, less than 10 mm, ovary more than 10 cysts. Girl with irregular periods and excessive hair. What is it? PCOS. First line. Remember, PCOS में first line for excessive hair growth is combined hormonal pills. For irregular periods, the best is combined hormonal pills. Always remember, no, sorry. They have asked the first line. The first line. They have not asked the treatment of choice. In PCOS, always and always make it a thumb rule. The first line is lifestyle. Just by changing lifestyle, 30% patient will improvise. They will not even need it. The treatment of choice is OCPs, but the first line is lifestyle. Also remember, in hirsutism, you might get an option of anti-androgens. Anti-androgens are not the first line. You always use combined hormonal pills first. If patient doesn't respond, you go to anti-androgens. But the first line is always lifestyle. LS surge. That graph, LH surge, why it happens? Why the LH surge happens? Suddenly LH was silent. Why it surges? High estradiol. High estradiol for 48 hours results in LH surge. Testosterone is secreted from which cells? So, if you take the seminiferous tissues, it has two types of cells. One are Sertoli cells, where the spermatogenesis happens. Outside are the Leydig cells. Leydig cells secrete testosterone. What does Sertoli cells? Androgen binding protein, so that high testosterone can be bound inside here, and some is released in blood. It releases Mullerian inhibiting substance. It secretes inhibin. All that is secreted by Sertoli cells. Ovarian drilling. Remember, whenever you see a picture of ovary with holes, it is only one place where drilling is done. In infertile patient of PCOS, you want her to ovulate. So what do? You drill holes. What are you doing? You are rupturing the follicles. These follicles are synthesizing the androgen. You are rupturing them so that the ovulation should start. Endometriosis. A patient with dysmenorrhea, dyspareunia, Bristol. When this and this is present, and you can see a nodule. Dysmenorrhea and dyspareunia can be because of adenomyosis. But when you see a nodule, it is endometriosis. What else question might write? Infertility is there in endometriosis. Uterus is normal in size. Uterus here is large. Uterus is fixed. It is not mobile. Here it is very soft and mobile and tender. They both present similarly, but examination finding is different. Gold standard for diagnosis of endometriosis. Everything is happening outside uterus. Small microscopic lesion outside uterus. Can you see them on ultrasound? CA125 and MRI? Laparoscopy. Go inside, see those nodules, take a biopsy. Again, just revise. Diagnosis for adenomyosis. What is the diagnostic gold standard for adenomyosis? MR. It is no more histopathology, MR. Gold standard for fibroid, ultrasound. Gold standard for endometrial polyp, hysteroscopy. Gold standard for Asherman, hysteroscopy. Best management to prevent recurrence of endometriotic cyst, also called as chocolate cyst. Remove the cyst. Just by drilling hole and sucking it, cyst will form again. You have to do the cystectomy. You do not do oophorectomy. Oophorectomy is not done. Don't remove her ovaries. Only cystectomy is done. Cyst ablation or aspiration will result in cyst formation again. Para to life to 36-year-old with severe, so many questions on endometriosis. So many. Severe endometriosis, pelvic adhesions. What will you do? When it is severe and so many adhesions are there, you will you will remove the adhesions, you will remove the uterus. It might be very painful for this lady. You also remove the ovaries, while otherwise endometriosis will form again. Since endometriosis can form again, you will remove the ovaries also. Okay. Gynecology, many questions have been asked. Most common cancer in the women worldwide. Worldwide, most common cancer, breast cancer. So overall, most common cancer is worldwide is breast cancer. Most common genital cancer worldwide, endometrial. Most common genital cancer in our country, cancer cervix. But overall, the most common cancer in our country and worldwide is breast. Cancer cervix comes after breast cancer. Okay? Most common cancer in men, lungs. Management of cancer cervix stage 1B. How will you remember? So remember, stage 1A1 is very microscopic, very small stage. You will do simple hysterectomy. When it is a simple stage, you will do simple hysterectomy. Why to do extensive surgeries? Okay? Now, when it is a little bigger, 1A2, okay, you need a modified radical. Radical means remove everything. So don't remove everything, you do a modified radical. It is a little extensive than simple, but sick. Little extensive, but not radical. In stage 1B till stage 2A1, radical. It means you not only remove uterus and ovaries, you remove the ligaments, you remove the peritoneal layers, you do a good dissection of uterine artery, everything. That is radical. So 1A1 is simple hysterectomy, 1A2 is modified radical. Just a second. And 1B and 2A1 is radical hysterectomy. Okay? In 1A1 and 1A2, also remember one thing, the uterus preserving surgery can also be done. They are microscopic and on the cervix, I can preserve the uterus. What I can do? In 1A1, I can do conization. Remove a cone of cervix. Uterus preserve. In 1A2, what can I do? I can do modified radical trachelectomy. The cone of cervix is removed, vagina is also removed. But after that, the uterine preserving surgeries cannot be done. I can't preserve uterus. So the only surgical treatment after that is radical. And after 2A1, what about after 2A1? From 2A2, I can't do surgery now. Chemo, radiation. So for 1B, it is radical. HPV responsible for cancer cervix. 16, 18 cause 70%. So mostly it is 16, 18, 31, 33. 16, 18, 31, 33. Then it is 45. Then it is 52, 58. Okay. Stage 3B. I told you everything beyond 2A1. I can't now remove it. The only treatment is chemo radiation. What is co-test in cervical cancer? Co means together. When I read that together, HPV and liquid biopsy. It has to be repeated every 5 years. About cervical cancer screening, please remember, what is the starting age? 25 years. What is the primary test? HPV detection. How frequently repeated? 5 years. Till what age it is done? 65 years. Please remember these points. In a good, resourceful area, this is what to be done. Now, Indian guidelines specially mention low resource setting. So, if person mention low resource setting, then only in low resource setting, it means in poor areas, the starting age, 30 years. The test, via visual inspection. Okay? So, this is in low resource area. How many times? At least twice in the lifetime. At least twice in her lifetime. If person doesn't mention low resource, this criteria has to be. In cervical cancer, what type of radiotherapy and chemotherapy is used? Platinum based. Platinum based chemoradiotherapy is used. Radiotherapy is done by a brachytherapy. Brachytherapy means you insert something in the cervix. Brachytherapy is when you release the radiation just near the source of cancer. You insert the tendon in the cervix, that is brachytherapy, and chemo, you give platinum based chemotherapy 6 cycles. A woman has adnexal mass and a mass in uterus with endometrial hemorrhage. It's a difficult question. Can it be endometrial cancer that has gone to the ovary? Yes, but they have given it is hyperplasia. It is not cancer. Hyperplasia is just thick endometrium, not cancer. It can be metastasis from endometrial cancer, but they have clearly given it is hyperplasia. It is not cancer. So where this mass in uterus with hyperplasia and adnexal mass is coming? It is some ovarian tumor going to the uterus. Why uterus wall is getting thicker? Because that ovarian tumor is hormone secreting. Granulosa cell tumors secrete estrogen hormone that is resulting in hyperplasia. Can both primary cancers, means ovarian cancer, endometrial cancer together? Very rare. Very unlucky women, very rare. PCS with endometrial hyperplasia, PCS will not have adnexal mass. PCS is bulky ovaries, not a mass. Okay, so this is most appropriate. We don't know what is the answer, but this is most appropriate. Which is the most common ovarian cancer? Epithelial cell. In that also most common ovarian cancer is serous. Serous carcinoma is most common. Most common germ cell tumor, this germ. Hormone secreting granulosa cell tumor. Androgen secreting Sertoli Leydig cell. They secrete androgens. Treatment of endometrial hyperplasia without atypia. If there is no atypia, the risk of cancer is 3%. If there is atypia, the risk of cancer is 30%. So treatment is different. No atypia, give her progesterones. That will reduce the hyperplasia. Give her progesterone, best is mirror. First. But if it is hyperplasia with atypia, very high cancers. The treatment is hysterectomy. I can't keep this uterus, very high risk. Hysterectomy. Gold standard for diagnosis of endometrial hyperplasia. How am I going to diagnose it is hyperplastic? It's a biopsy finding. Do a hysteroscopy and get a biopsy. That is best. Pipples. Though doing hysteroscopy and getting biopsy is best, but we can't do hysteroscopy in everyone. What do we do? Office biopsy. Office biopsy using pipettes. It's a thin pen-like, refill-like structure. Introduce it, take the sample. Hysteroscopy biopsy is the best way of taking sample, but we can't do it. So the most common one is pipples biopsy or endometrium. Okay. What do we use for HSG? Use Leach, Wilkinson, cannula. That is used. Prolapse, fistula, and pelvic floor. So now the questions on prolapse. We will quickly finish it now. We are closing to the finishing time now. 75-year-old, she is quite old with vaginal bulge for years. Now examination shows UV prolapse outside the uterus. What do you do? So hysterectomy in 75 years old, immediately not the initial. Not it might be the definitive, but so hysterectomy might be one of the best treatment, but not the initial. In such a old lady, you will always try something more conservative. Now it is coming outside, so just exercises is not possible. You will not observe it is coming outside. The best right now is passive. If they ask the definitive management, it is not initial. Definitive. Definitive is hysterectomy. But right now, initial in 75-year-old is the passive. Now, just remember the treatment for various types of prolapse. When it is an anterior wall prolapse means cystocele and erythrocele. The treatment is anterior colporaphy. It means tightening of the anterior pelvis. When it is posterior wall prolapse, which is rectocele, not enterocele, rectocele. It is posterior colporaphy. When it is apical prolapse. Now, apical prolapse can be of two types. Either the uterus prolapsing, where the definitive is hysterectomy. We discussed if hysterectomy not done, then passive. Enterocele. Yes, the intestine, the bowel coming out is also apical prolapse. And the treatment of enterocele is The cul-de-sac, the pouch of Douglas through which it is coming out, tighten it. We call it culdoplasty. And it is named on the scientist, Meckel culdoplasty for enteric. If it is a very debilitating woman, very sick woman, you can't do surgeries. Leave it. You close the vagina, approximate everything and close it. Okay? If you want to preserve uterus, if it's a young woman and you want to preserve uterus, don't want to do hysterectomy, then the best is sacro, hysteropexy. Via a mesh, you take the uterus, pull it up and stitch it to the anterior sacral ligament. Sacro, hysteropexy. Remember this. Simple. POPQ classification, when you give the various A, B, they are measured from which reference point? Hind. It's a theoretical question. A woman with involuntary leakage during the workout, during exercise, it means during stress, during workout, her sphincter is very loose, stress and loose. If whenever she has an urge to urinate, she can't reach the washroom and she leaks. So she leaks whenever she has an urge to urinate. She can't hold it, urgent, which is most common, stress incontinence. Safest type of hysterectomy for ureteric injuries. Yes, ureteric injuries are very common in hysterectomy, but the safest is vaginal. When you do vaginal hysterectomy, uterus is far above. You can't injure the uterus. Abdominally, the hysterectomy with highest risk of ureteric injury, highest risk. Radical. When you are removing everything, there are chances you will injure the uterus. In sections. Now, thin frothy discharge, strawberry cells. Motility on microscopy. What it is? Trichomonas. Now, remember various kind of infections. Whenever the question gives you the gray discharge plus whiff test, yani fishy odor, plus flu cells, plus Amsel criteria. When you see these names, it is bacterial vaginosis. When you see the strawberry cells, when you see motile organism, you can see actually moving them, the motile organisms, and it's a greenish discharge. Trichomonas. It's a motile flagellated organism. Whenever it is excess itching, excess, see all of them have itching, but excess itching, inflammation of vulva, plus curdy discharge, and microscopy may you see budding cells. It is candida infection. So remember these for various infections. For bacterial vaginosis and trichomonas, the treatment is metronidazole. For candida, the treatment is antifungal fluconazole. Which STI require both male and female treatment? If it is sexually transmitted, you will treat both male and female. Candida is not considered STI. Bacterial vaginosis is not STI. It is trichomonas. Herpes is an STI, but remember viral illnesses. The partner treatment is not. Herpes, warts, which is by human papilloma virus, you do not treat the partner. You only treat the patient. It is an STI, yes, but in viral illnesses, you don't treat the partner. In the rest, all STI, you treat the partner. Candida and bacterial vaginosis are not an STI. They are not coming from partner. Amsel criteria, we just discussed bacterial vaginosis. Lady with lower abdominal pain, restricted movement, laparoscopy showed trickling through femoral ends. PID. What is the treatment for PID? PID is caused by two organisms, chlamydia and gonorrhea. So you give antibiotics for both. For chlamydia, you will give doxycycline. For gonorrhea, you will give ceftriaxone. And you will add metronidazole because such an infection will have bacterial vaginosis also. Ectopic pregnancy. So now in ectopic pregnancy, yes. What is the most common site of ectopic? The site where fertilization takes place. Ampulla. Most common site for tuberculosis to happen? Ampulla. Characteristic of ultrasound in ectopic. Ectopic is whenever uterus is empty and you see an adnexal mass. Remember, in a patient who is UPT positive and who's always in fainting or who's in shock, UPT positive patient in shock should be considered ectopic unless and until otherwise. Ultrasound will show empty uterus and Dexel mass, and fluid in pouch of Douglas is blood. Thin endometrium, no Dexel mass. Intrauterine G-sac, if it is visible, it cannot get. Best marker for HCG. Best marker for molar pregnancy, HCG. Best marker for ovarian cancer, CA125. Best marker for for predicting ovulation. Best marker for predicting ovulation. When will ovulation happen? When it is about to happen? LH. A 28-year-old pregnant woman shows snowstorm appearance. Snowstorm is molar pregnancy. What is the treatment for molar? I always tell molar you don't give, these are vesicles filling it. You have to remove them. So it is always suction evacuation. You don't give methotrexate in molar. You always do suction evacuation. You follow with beta HCG. If beta HCG is high, it means it is no more molar. It is gestational prophylactic neoplasia. It is choriocarcinoma. In that, you give methotrexate. So methotrexate is given in choriocarcinoma. The treatment for molar is suction. Do the suction, remove. 46XX KIP2 negative on immunohistochemistry indicates which pathology. KIP2 negative comes from the maternal chromosomes. It comes from the maternal chromosomes. It was a difficult question. Yes. So somebody who doesn't have maternal chromosomes, has only paternal chromosomes, will be the one not having KIP2. So all of us are KIP2 positive. Okay? So what pathology doesn't have maternal chromosome? Empty ovum, fertilized by 2 sperms. Completely. Partial mole is a proper ovum, fertilized by 2 sperms. Okay? It is 69 chromosomes. KIP2 positive. This is an empty ovum fertilized by 2 sperms. This is KIP2 negative. Okay? Most DNC. Patient develops secondary ending. DNC के बाद I know it is Ashok. Progesterone challenge test shows both tests negative. What is it? Ashok. What is progesterone challenge test? In secondary amenorrhea, to diagnose the reason, if patient has secondary amenorrhea, what do? I do progesterone challenge test. I give progesterone for 10 days. I give progesterone for 10 days and I withdraw. Withdrawing the progesterone should ideally cause menses. If menses come, it means patient was lacking progesterone. You gave the progesterone, menses came. Why was she lacking progesterone? Progesterone forms only and only after ovulation. So it is a case of anovulation. It will be PCOS. Suppose menses don't come. You give progesterone for 10 days, menses don't come. Now you give her estrogen and progesterone both. Estrogen for 28 days, progesterone in last 10 days. You give both. Now the endometrium gets prepared and now it starts bleeding. Now shortly. It means patient was lacking estrogen. Endometrium was not prepared. You gave estrogen, patient started bleeding. So patient is hypoestrogenic, either ovarian failure or some central cause. To differentiate, I'll get FSH. If even after giving progesterone and estrogen, patient has still no menses, it means the problem is not hormonal. You gave estrogen, you gave progesterone, still no bleeding. The problem is not of hormones. Patient is of endometrial problem, Asherman. The diagnostic test I told you for Asherman is hysterectomy. So all the questions have been done. That was a quick revision. We don't have time. Do very, very good. Best of luck, everyone. Just be confident. Just be confident. Whenever you are seeing a question, you seeing an answer, whatever comes to your mind, mark it. Do not think every question as a puzzle. It's not puzzle. Questions are generally straightforward. So whenever question is straightforward, please Mark whatever seems right. Don't overthink. Best of luck.